There you go. So, good morning. Happy Friday to you all, and welcome to another session of the Extracorporeal Hour. Um, we don't have anybody that has signed up to present a topic today, but we'll be happy to take any last minute volunteer if you want to discuss a topic or present a case. And as always, we also welcome you to turn on your webcams, introduce yourself if you're new to the rounds or haven't introduced yourself yet. Um, and after a while, we'll just get it going.
How's it going, guys?
Hey,
Sha-
chap.
Hey,
Chap, when your
Chad.
Chap.
name shows up, you usually have something good to share.
Oh, not this time. I'm just actually a little bit laid up and sick, so it worked out perfect. I was like, well, I'll take advantage of my sitting down time and log in and see what you guys have going on. We always have some fun stuff going on, but it's been a little bit quieter on our end of it too. So always happy to finagle up some questions. We've been playing with some skippies and just sort of doing some different things along those lines. And
Oh yeah. How did the dice go, by the way?
they went pretty
So I got
well. So
we had a debate about which die was the best to run a skippy for demonstrating hemodialysis principles. So between the which one did you have?
So yeah, we'd actually gotten a couple of different ones, and it's sort of interesting. I probably spent more time than I have ever looking at dyes, but we went and got a McCormick brand. But even within some of the McCormick brands, I think we were seeing a little bit of variation in between how they sort of made things up. And so, looking at the molecular weight, I think one of them that we got. I think the bottle my nurse ended up picking up was a red, yellow, and blue.
Uh,
And I think we ended up using, we just did a fluid bag, an empty fluid bag, fill it with some water, and ended up, I think we mixed together a combo of blue and yellow. Their McCormick, their blue, they actually made it up with, I think is 5 and 40 red. And like the molecular weights were like 534 and 596. And I think with the blue, they used red 40 and then blue one, or sorry, yellow one it was the other one, but blue one and then red 40. And that one actually, that blue one has a molecular weight of about 798 versus 496. And so we sort of did like 12 drops of each of them in the bags, and turned out to be a pretty dark color. I think it was like a dark green, turned a bit light as we sort of went through treatment, and then eventually cleared out about an hour later or so, just running dialysis. So we're playing with a couple of different kinds. I went and bought some generic ones to see if I could get a little bit more of a profound response.
Yeah, so maybe just to give some context to the other listeners on the call. So Chad contacted me this week because he wanted to set up a lab with a skippy to demonstrate the principles of hemodialysis for CSU students, I think. Um, because that's always the thing when you have an extractable unit and you get some visitors is you rarely have a case to show them. It's kind of like a rule of thumb, like you never have a case when you need one. And then it's always interesting for visiting students or visiting residents to, well, set up the machine and then get it going and try to demonstrate some principles. The problem is that you need to find the right dyes so you can have one that diffuses pretty well that you can clear with just hemodialysis. And ideally, you want another one that doesn't diffuse so well, so you can demonstrate like the cutoff of your membrane or the addition of convection, and now we can clear middle molecules a little bit more. But obviously, there's no off-the-shelf product to do that, at least not that I know. So you always play with some food dyes and try to find the right one to demonstrate the principles that you want to show. But I don't know if anybody has some tricks that they use in their unit to set up those labs and um, when they have students or visitors. And I mean, any tip and trick would be welcome, I think, because I mean, I think we've all been to those renal weeks labs that are really telling, I think, in terms of hemodialysis principles, but it's not always easy to replicate them later on when you don't have the right dye. And the one that Dr. Cargill was strictly using, I think, is not on the market anymore. So there you go. So we were trying the McCormick's, but if anyone has another recipe, just let's hear it, maybe.
Yeah, thanks for giving that context. And for sure, I'll if I find something else too. We've been playing around with a little bit of new methylene blue and things like that. I think actually it was Rafa had done that and played a little bit with some new methylene blue on a carbon as well, which has been sort of interesting. So yeah, just play with a bunch of different types of dye and see if we can play with some different principles and see what we can make happen for sure.
Yeah, the methylene blue actually did work pretty great for perfusion. So we cleared out all of the blue.
Yeah, nice.
I've done that with the McCormick's. I've only used the McCormick's, but the red and the blue, I think both worked on carbon for me. And then I use those guys on the hemodialysis platform too. Becky's got her hand out. What do you have to say, Becky?
Hey, I hadn't thought about this before. I have a hobby of spinning and dyeing yarn. So I'm kind of wondering if any of the pigments that I use might be helpful. It might be something that I can check in with Erica about trying on some of our practice setups.
Yeah, well, I think the whole point is it's not always easy to know what kind of pigments they use and if they're, how much water soluble they are and what's their molecular weight and things like that. So I don't know if you have access to any of that information to just like maybe select a few that look like the best candidate and then just like try them. Because I mean, especially in an academic context, again, I feel like it's always nice, like I kind of feel dumb to speak about dialysis in front of a machine that's not running with residents. So anytime we can set up a lab, I think is more interesting.
Yeah, I have a little bit of the information on like what's going to bind to what's going to make it bind more and things like that, depending on if you're using like acid dyes and natural pigments and things like that. So I'll look into it and see if I can figure out something that might be helpful.
Right. We're gonna come up with some brand new colors for labs. That's gonna be fun.
I
mean, Renal Week is in a year from now, so you got ample time to test all of those.
I was just going to comment because we switched from the Phoenix to the Blue Star, and I'm sure everybody who has the Blue Star on here is aware, but the red and the blue dye gives a blood and dialysate alarm. So at least that's what happened to us. So we have switched to using green McCormick dye, but I haven't tried other things.
Yeah, that one works well.
Yeah, it works okay. Yeah, it doesn't give the blood and dialysate alarm and it's dialyzed off. The other thing I'll say, because Rafa mentioned methylene blue, is I remember finding a case report of a person who was dialyzed with the Fresenius Blue Star with methylene blue, and it set off the blood and dialysate alarm. So I don't think methylene blue is also an option
You're right.
on the Blue Star, just because the way.
Actually,
Yeah.
it also reminds me of another case report. I mean, I don't think any of us will be in that configuration anytime soon, but they had the same problem by dialyzing a patient who was receiving doxorubicin.
Interesting.
And they had some blood in dialysate alarms as well, and they had to stop the treatment, and they figured it out later. So, I mean, those are the kind of things where sometimes you can have an error or an alarm that you don't understand, and that's why it's very important to know your machine very well and know how it's looking at things to try to understand what happened later on. But yeah, those case reports I think are funny, and it's nice that they report them because I wouldn't have thought of that at all.
And Erica, you said you had good luck with the green. Do you know if the McCormick green was like made of a combo of colors and you saw a change in dialysate color, or was it just dialyzable?
You guys are so scientific. I mean, literally, you just like bought the dye, like put it in a bag, and wait
Works.
for it to be dialyzed off. Yeah, wow. I'm impressed with this team.
Erica,
Yeah.
I'm really glad you just said that out loud because I was having the same like, what am I doing with my dyes? Because I'm not looking at that tight.
Well, I think I'd love to claim credit, but I think it was Sherry who'd shown me, and it was like one color, then changed colors, and I was like, "Oh,
Yeah.
that's so cool!" And I've been slacking on mimicking that. That's I'm
So
like, okay,
agree.
well,
Yeah.
get a little.
So I'm looking at it right now, and it's actually yellow 5 and blue 1.
Okay.
Here's for your curiosity, chap. So
Perfect. So yeah, that blue one, based on what I looked at, it has like a molecular weight of around 800. And you said the yellow 5 is like 534 is what I sort of looked up. So you could definitely see, well, you could potentially see a little bit of a change in
yeah,
color. And I'll try
I will
to.
take your word for it.
It was a fun rabbit hole with a lack of cases. I think my poor interns were a little bit bored, but.
Can I actually bring up a case
Sure.
that I recently had? Just actually went home a couple of days ago.
Do you have a webcam or do you have slides to share?
Well, so that's a problem. I'm not prepared. So
No problem. That's fine.
I'm home and I have a few pictures of what we did, but they're not
Nice.
as interesting, honestly. So if that's okay, I'll just chat. All right, so I have Zeus. This is a 10-year-old mixed breed, big, fat, pit kind of dog, 33 kilograms. He came in with intravascular IMHA, pretty class. Actually, yeah, when he came in, it wasn't that obvious that it was intravascular, didn't have obvious pigmenturia. His PCV was in the low 20s. His bilirubin, I think, was only 6. So we started treatment just with, Pred, Atopica, for the first 48 hours. And as initially didn't seem to be that terrible of a hemolysis. And then obviously he turned and started having horrible pigmenturia. He needed 1 transfusion. His bilirubin skyrocketed to, I don't know what number, because we couldn't dilute it enough to get a reading in the in-house machine. And so we decided to do plasmapheresis. We do it on the Prismax. Unfortunately, we don't have centrifugal. And so his first treatment, he didn't quite do 1.5 plasma volumes. He got to, I think, 1.3, and then he clotted the circuit, and we had to stop. Post plasmapheresis, his bilirubin had gone down to a number that we doing like some kind of janky dilution in the machine was like, I think 15. This is post. And dog was like significantly neurologic at that point. And 2 hours later proceeded to start having generalized seizures, which responded to midazolam. And then we started him on Keppra. So next day, I wasn't on. Actually, my colleague decided not to do another treatment because she was so worried about, honestly, having caused some of the neurological signs. Looking back, honestly, I think it was mostly induced by carnicterus, maybe had some vascular events, clottings but I honestly think it was mostly carnicterus. And next day, again, we couldn't get any number for his bilirubin. And So he was not treated for another 2 days. And then I went in and I did 2 back-to-back treatments. And I was able to dilute his, or like knock down his bilirubin to 70 was the first number that we got. And as the bilirubin started coming down, his neurological signs began to improve. And I think it was like extremely interesting because like we could see on a daily basis dog like starting to become more responsive. It was non-ambulatory. Well, initially it was tetraplegic when he first woke up. It was like literally in a coma for a couple of days. And then no more seizures, but slowly became like a little bit of motor came back, started becoming a little more alert. And he ended up being in the hospital for 12 days. We only did 3 treatments. What I wanted to do, honestly, was to try a hemoperfusion with not the cytosorb, the amylogic one. Sorry, I can't remember the name. But I'm very new to hemoperfusion on the Prismax. So I had not done a skippy yet. We had just gotten the columns, so I decided to hold. I wanted to try some skippies first. And he ended up going home a couple of days ago, still non-ambulatory, but getting a lot stronger and starting to eat. And we got a call yesterday from the owner that he started standing up, weak, but at least he's standing up now. So the interesting thing to me is that this dog only got 1 blood transfusion, but his bilirubin was so high. And I don't know, I wanted to see what you guys think about his neurological signs, because he's all be carnicterus or was more of a vascular event. Obviously, we have not run an MRI, which would have been very nice, but these people already spent $40,000, so couldn't add on to that. And putting him under general anesthesia was not our priority, honestly. So he ended up like seemingly doing great. His last PCV was 34%. But I don't know if you guys have ever seen like these dramatic spikes in bilirubin in spite of, again, just 1 blood transfusion.
I've definitely experienced exactly what you described clinically speaking, and that kind of acute hyperbilirubinemia encephalopathy, is I think we've all recognized that. I wonder though, but to your point, like it's usually for me, the bilirubin's been climbing up in the 50s to 60s after a couple of transfusions. Was there any evidence of hemolysis after that first treatment that you did to help explain why the bilirubin skyrocketed?
Yes, he was still having terrible pigmenturia.
I mean, I guess, was there anything that you could tie to the treatment as opposed to his underlying disease? I know it's probably hard to tease out.
I don't think so. That's what I keep thinking. Okay. Like, did we cause some of that? But I honestly can't think of what that would have been.
And Rafa, I think you said the total bili was 6 pre-transfusion, right?
The on presentation.
Uh-huh. And it was after that single transfusion that you saw that huge spike.
Correct. Yes. One other thought that I had is that this dog is very fat, and like maybe is accumulating lots of bilirubin there as opposed to liver processing it, just for like volume distribution standpoint.
Yeah, I think it would equilibrate across the two. But do you think his disease was under control after the first one? I'm kind of surprised with the story that he only needed the 1 transfusion.
Right, exactly. That's what I can't make sense of.
How low did
1 transfusion? How low his PCV was? Let me see. pull it up actually. I think sorry, again, I was not prepared.
No, this is perfect. We love these. This is exactly how these conversations can go. Like some of us put the presentations together. I'm going to talk a little bit to give you some space to look for the stuff you're looking for. But no, this is perfect. This kind of off the cuffs presentation is exactly what we're after.
I wrote
interesting.
more time. Sorry, Shep. We had a similar case. It was a 10-month-old dog that we actually wrote up and published that after its first transfusion had like a markedly elevated bilirubin. Similarly, it went from like 1.7 to 17 to 49, like 6 hours before we TPE'd the dog. And then the dog,
I saw that paper, yeah.
Yeah, the dog developed pretty severe clinical signs, and we didn't MRI the dog either to know whether it was a clot versus bilirubin encephalopathy, but we suspected it was bilirubin encephalopathy. That dog was transfusion dependent, but we have a centrifugal platform, and I do think in the centrifugal platform we do see some lysis of cells when they're very, very fragile. So I think some of her transfusion dependent was just from some of it, the machine.
Like the machine inducing the lysis?
Yeah, like I don't know if anyone else has seen that with their centrifugal machine, but sometimes we'll start the treatment and the plasma will look like, a little red, and then by the end it's very, very red. I think other people have talked about this before. I just think the cells, and we talked about it in the discussion of the paper, that I think these cells are just very, very fragile, and when we put them in the centrifuge, potentially it causes some additional lysis. But yeah, our dog needed a lot more blood, and remained transfusion dependent. We ended up doing 4 TPEs before she stopped needing blood.
So say we induce that with our treatment, like what could have we done differently to avoid hemolysis from the machine? Like I think the blood flow rate that we had it was never above 120, 130, which I don't think is super high. TMP were always in the 15 to 20, obviously, like the first treatment when he clotted the circuit, he did have a spiky TMP when there was a clot. But beyond that, yeah, go ahead. Sorry.
Oh, sorry. I was just gonna say I'm going to take this down here and then focus more on your case. But this was a recent case that we had where after one transfusion, you can see it, the bilirubin spiked to 30, the second one, and this was before any TPE treatments as well. So it's certainly can happen even with just the one transfusion that we were seeing as well. I think we're all sharing that experience with you.
Yeah, it'd be curious. We've had similar cases, and we've explored, the idea of do we do more extensive, when we get these guys back, do we do more intensive blood typing? And, do we reevaluate some of our cross matches beforehand? We've tended to migrate, probably like a lot of people, just due to cost and timing, a bit away from a lot of cross matching as we're looking at this. But we've thought about that as well as sort of timing of transfusions. Timing and technique of transfusions. We tend to do some more blood priming in these guys. And I've certainly seen with dilution of packed red blood cells, less hemolysis, and hemolysis with both platforms. But I guess, Erica, it's sort of interesting. I'll have to think back and look back at our cases. I feel like I see less with the centrifugal than I did when we were doing much more with the membrane-based therapies. But that could have also just been technique, because we started out with the Prismax and then added on the centrifugal a little bit later on. So maybe that was hopefully a sign of us doing something better in the long term.
Yeah, the caveat being like I really only see that in the truly intravascular cases where I wonder if the centrifuge is spinning the cells and making them rupture. I think they don't have such severe intravascular disease. I don't tend to see it.
That makes sense.
And I only get the bad ones because at our practice, we only treat them when they're dying, like Rafa's case. Like it's so unfair. I hear these other cases that are like stable, and I only get the ones literally that are neurologic and dying. So
Oh,
that's
you're gonna have to train your internal medicine team.
yeah, I mean they offer it earlier, but it's cheaper to just keep transfusing them. So yeah, a lot of owners delay, and eventually a lot of the dogs have responded to immunosuppressives, the ones I haven't treated that we've offered it early and they've declined.
Make your red blood cell transfusion more expensive then. I'm joking.
Yeah. Yeah, exactly.
But yeah, did you guys have any blood typing or cross matching or anything like that on that dog by chance?
Blood typing, yes, it was DA positive. We did not cross match it. Is the lowest his PCV went was 20% when he needed his transfusion. It was very symptomatic for it, and that's also when we started seeing the terrible pigmenturia that prompt us to starting treating with plasmapheresis.
And did you use any blood products as replacement fluids for him?
Just plasma.
Just plasma. Okay.
Yeah. Oh, speaking of, I don't know if you guys have the same issues, but apparently there's no starches available anywhere anymore.
Yeah,
we're on back order.
Yeah, same problem here.
So what do we do for replacement? Because for us, plasma only is gonna be like plasma and say like other S is gonna be
crystalloids.
Not feasible. Yeah, not feasible.
Yeah, no, that's the same challenge that we faced, and so I've tried to incorporate more red cells in my replacements a little bit as well if they're on the verge of it, to try and get some of that volume made up. But I've been slowing down, and I've been doing a little bit of plasma, a little bit of crystalloid, a little bit of plasma, a little bit of crystalloid, just trying to kind of balance out what I'm giving as replacement so that some of it, most of it, more of it stays in the intravascular space. But it's been a challenge. I don't know what other folks are doing.
I mean, in San Diego, I just decided to give more plasma, like increase the portion of plasma. It definitely increases the cost of the treatment, but I don't see any good alternative so far. I mean, I know that now in California we can have access to canine albumin, like that reconstitutable powder. But at the end of the day, when you look at the price, it's almost as expensive as plasma. So I don't really see the point, and I haven't tried it yet. I know that the team in Switzerland, Thierry, he was using some human albumin at some point, but I've always kind of stayed away from that because I'm so worried about creating more problem with alloimmunization and things like that. But yeah, I agree that the fact that we don't have access to either vet starch or Eda starch or even dextran would be an option, and it just makes it more challenging, or at least more expensive, I should say, because you can always give more plasma. The thing where I'm not completely comfortable with right now is how much crystalloids can I give without risking hypotension 30, 45 minutes into the treatment, because that's a problem. You're going to do isovolumic replacement at the beginning. That's fine, but that saline is going to redistribute pretty fast. So yeah, like I don't know, how do you calculate how much crystalloid you're giving on those treatments, Jethro or Erica?
Yeah, my original, like, I pick my total volume exchange, that I'm planning for 1.5 usually. And I start going through my freezer and see, can I get 50% or more of a plasma product? And that's where I've started. And now, kind of like you, I've kind of nudged that up. I'll take one more unit to account for my lack of a synthetic starch. So I'm trying to get in that 50-60% range of a plasma product. And then whatever I can do, a lot of it, I will say I have this volume I'm trying to go for, but the patient really dictates how much I actually end up being able to exchange. Or sometimes I thaw an extra bag of plasma if I'm seeing hypotension and I'm watching my crit line and my volume's just leaving right off when I'm given the crystalloids or 15 minutes later, then I have to adjust my plan on the fly and either use more plasma products or less total volume exchanged, or I'm giving peripheral fluid sometimes as well.
I think
It's a dance.
yeah, I have the same approach. We just had a starch back in. I don't know if you saw Becky's comment. So sorry for you guys, but we got it back. But my plan was similar to what you guys mentioned, just probably do a bit more plasma to compensate for not being able to give the colloid at the beginning. But I usually aim for around 50 to 60% plasma replacement.
Yeah, we've been doing the same in our smaller patients. I think we're, almost exclusively going to plasma for replacement when we're doing it on the carpe diem and such, just because they are so much smaller and tend to be a little bit more of a challenge from the hemodynamic process, especially in those like sort of 1.5 to 2 kg patients. And then you have less on the plasma side of it. We had in the early times when we were having a tough time getting everything stocked up, used frozen plasma as a component of our therapy in the early stages of things. I think with albumin and all of that, and we went through quite a bit of frozen plasma that's been gone sort of by the wayside with us trying to make efforts to get the cost down and such. But I think it does also highlight the importance of a sustainable blood bank in order to have a sustainable extracorporeal sort of setup and system, because you're going to fight these challenges of these synthetics, and while they're okay, they also have their limits that we have to be aware of with the human serum albumin option, availability and cost, and all of those other components. I think it's critically important and something that we continue to drive home. I say that in the face of us shutting ours down, but it's something that I think is very important and critical, and something we're going to feel the pinch of here soon.
Is there anybody else on here that has a different approach that's doing plasma exchange? I saw Christine on here earlier, but I don't see her still signed in. I mean, back to your case, you had asked, what kinds of things might cause hemolysis during the treatment, and I think everything you described as far as your blood flow rates and your TMPs, unless I think I have seen, maybe not to the degree that you're describing, things get a little bit worse, as those cells are, how fragile are they as they're being thrust through the membranes. And through the straws, there may be some hemolysis that happens as a result of that, but I've seen more of those TMPs go up and have problems with that to kind of give me some clues that's part of the underlying problem as well. Unless there was clotting in your circuit somewhere that you would recognize other higher pressures that could be, shearing red blood cells as they're going past those clots. Those are just a couple of thoughts, but it doesn't sound like, from what you described, that those things were happening.
Yeah, not obviously, at least. Obviously, I could have very well missed it, but yeah, not obviously.
The other thing that I would like to mention with centrifugal TPE, and it's just a feeling I have. I have no proof of that, but in the patient where we do blood prime, I've seen that phenomenon that Erica was describing, where you start the treatment, the plasma starts to come out like pretty clear and tends to go redder right after the beginning of the treatment. And I've had some suspicion at some point that the hemolysis that was happening was actually not the patient's red blood cells, but might also be from the back red blood cells that we use for the blood prime. And I felt that every time I'm asking for back red blood cells to the blood bank for these patients, I get the unit that's going to expire tomorrow, because obviously they're like very cautious with their resources. But if you get a fresh unit of back red blood cells, or even better, sometimes some whole blood, I feel like I don't see that phenomenon as much. So I wonder if aging red blood cells have also more fragility, which may not be so much of a problem for transfusion, but might be more a problem when we are running them through extracorporeal circuits. And that's something I would like to look into at some point. I haven't found a real way to do that. But yeah, I've been a little more demanding with our blood bank and say, hey, can I get fresh unit for this patient? And I feel like things are going somehow better in these cases.
Cedric, on your blood primes, are you diluting out your unit at all, or are you giving
I
just the
am.
concentrated? Okay. I think that's
Yeah, I
another
am.
component that we've seen variations too. I don't know if you guys have seen the same to cause you to do that.
And I'm usually, especially when I have a very small patient, I think we need to remember that the reason why we blood prime is because we need to bring some oxygen carrying capacity, but we also need to provide some colloid support. And if you're blood priming the Optia circuit, which is like 150 mils or something, I think, only with packed red blood cells, you're going to face the same problem with hypertension. So I usually tend to use some of my replacement plasma to mix with the packed red blood cells to do my blood prime. In some of the cases, I've used vet starch as well, but like half strength vet starch to try to get something that would be more physiologic in terms of colloid support. I don't know if that makes sense, but
Yeah, this has kind of been my recipe-ish. It varies a little bit depending on where my fluids are. But this was for the Prismax circuits that I did on a patient a little while back. I did dilute out the PRBCs, and they're pretty thick. They come out of the bag at 60%, I think. So to Cedric's point, to get some oncotic support there and make it a little more physiologic. I mean, essentially, I think we're creating somewhat of a whole blood product here with that concoction.
it's just like sometimes like why don't we just have whole blood? It would be just easier, right? The thing with packed red blood cells too, like especially if I'm using them on the Prismax, is I'm worried that I'm gonna clog that filter or that dialyzer thirst pass with my blood prime. Like if it's 60%, I mean, you wouldn't like your post-filter hematocrit to be 60% during your treatment. That's why we're working with low filtration fraction. So just like putting 60% hematocrit packed red blood cells to prime the circuit seems very counterintuitive to me. So same thing, I would probably dilute. I mean, they don't get to the filter at 60% because we're diluting saline progressively. But if you put a lot of them, you end up with having a pretty significant hematocrit in your circuit. So I kind of do the same. I like to have like some saline, some colloid support, and some packed red blood cells.
Yeah, I agree. I think you reduce that viscosity. It just makes everything run a lot more smooth. And you see that sort of reflected in the pressure changes and the alarms and things like that you get with the blood prime in particular.
And even more so, I think on the membrane base than the centrifugal.
Mm-hmm.
But so going back to the bilirubin problem, let's see if I can share my screen there. I don't have any slides because I was not prepared for that, but let's show that. You see my screen?
I don't know if you're pulling up. After you show some of these, I can show you how we integrated the vet rescue into the Prismax circuit for a TP
Well,
session.
that's a nice segue because I was going to get into that for the actually for the hemologic one. So that's a patient we got. Oh, can I go through my pictures there? It's gonna be annoying. So pretty icteric, as you can see, we treated with the Optia, and that's what the plasma look like. Like those are the plasma removal lines. So very hemolytic and icteric at the same time. And we you couldn't even see like the interface in the machine. Like that's just like you get the red blood cells and you get the plasma on top, but you can't really see where everything is starting or not. And for the first treatment, that was our first bag, treatment number 1. I just did a regular plasma exchange, And this is the bilirubin of the patient. So treatment number one, pre-treatment, the bilirubin was 30.9. And we did reduce it only to 21.7. And that's kind of been my experience, but usually with a 1.5 plasma exchange, we end up with like a 30 to 40% reduction. So for the second treatment, we decided to actually use a hemolytic cartridge. Okay, so that was my setup to prime the cartridge. So let's see. I'm sorry, the navigation is not very easy. So that I primed the cartridge on the side with saline, just like a line going to the cartridge and then a waste bag down there. You need to use all the connectors that you can get from molded products. So there's like some DIN to DIN connectors and then some Luer to DIN connectors, and you can like kind of makeshift your little priming kit like that. So yeah, so that's a patient on the machine, and like still pretty dark plasma there. And we were able to just like put so that we included the cartridge into the circuit. And so we just take the accessory line that is going, so that's a plasma going to the waste bag, but you've got an accessory line with that kind of yellow clamp, and we included the cartridge into the circuit that way. And after a while, we just redirected the plasma through the cartridge into a sterile bag in order to be able to, and you can tell like from that picture that you can see the bilirubin removal through the cartridge. So that's the plasma coming in, and that is plasma coming out. So that was the Dublin. So I think now they would be the ToxiClear. I didn't have any of the CytoClear, but potentially that could be a better option for those patients. Same thing, you can see the difference in color there. And so you get that bag, and then you just use that bag as replacement. And so that's what we did for that second treatment. And actually, the initial bilirubin was 47 for that second treatment, and we took it all the way down to 10.9. So kind of a better result. Even if I couldn't do plasma perfusion as much as I wanted, I think I did a 1.5 plasma exchange, like regular one. And then we did another half plasma volume with plasma perfusion. I was targeting to do more like an additional 1 to 1.5, but I had some technical difficulties with the machine, and I had to stop. So that's definitely an option. I feel like on the Prismax, you might want to actually put the cartridge on the Prismax directly in the blood flow. Instead of like doing plasma perfusion, you could do actually some hemoperfusion pre-filter in order to pull out your bilirubin. Yeah, just that way.
Yeah, so just to echo Cedric, if it's something, we talked about skippies at the start of this, but certainly there's a number of ways that we use, some of these great devices and attachments, these DIN to Luer connectors to prime all these guys and connect into our circuits. If you're not familiar with them, molded products, and then play around with some skippies. But very similar to what Cedric, you described. We've got the sterile spike set and priming set up for in this case the synthetic polymer bead vet rescue device. And incorporated it directly in. And that's what I would do in most of my treatments with carbon as well. I haven't got to, Cedric's, advanced level doing the plasma absorption and then reusing that plasma as replacement to extend the treatments. This has been the extent of how far I've taken it. But I think, for Rafa's case, putting the carbon into the circuit here, if that was the device you were going to choose. Your dog was big enough, so I don't think it would really challenge them with an extracorporeal circuit volume. I think it could have been a nice adjunct there. We'll say in my case, let's see if I've got that. Went through the prime here. In my case, it didn't work out amazing because of how inflammatory my patient was. And so I did have a lot of TMP alarms and ultimately ended up failing a set. I think because there were so many red blood cell and other inflammatory just debris getting clogged up in my membrane that I had to abandon. I abandoned the absorptive device and reset the whole circuit once during this was his first treatment to account for that. So a couple of patient factors in there as well, but I did use that absorptive device in the circuit directly.
I think that's where it might help to do, more of a plasma hemoperfusion based technique. I know Dan has set it up, but I was telling Rafa, it's certainly something to play with because you have to trick the machine a bit to do it. But he has done a plasma hemoperfusion or plasma perfusion sort of set up on the Prismax, just with some separate pumps to confuse your effluent or waste bag sort of weights. And so there's definitely ways to do it. Your level of risk and safety does increase a bit because you're just using so many external pumps unrelated to the platform. But certainly is a way to do it. And, I think has significant benefit, though, depending on what carbon or either carbon or polymer base you are probably missing a couple of those like red cells and other things that you might separate out if you're doing hemoperfusion. But I think you're doing away with less of the pressure type related issues.
I think that the easiest to include an hemoperfusion cartridge into the circuit is really on the Prismax at least, is really to use that setup to put it pre-filter, because you can directly use a inlet blood line from the pump to feed your cartridge right there. And then you just need that DIN-to-DIN connector to go from your cartridge up into either the dialyzer, depending, or the plasma filter, depending on what you're doing. So yeah, I feel like that's pretty straightforward. That's another picture. The thing that I would like to bring up though is to me it's pretty different to include the cartridge that way into your circuit and doing plasma perfusion. And you have to weigh the pros and cons, I think. If you include the hemoperfusion cartridge in your circuit before your plasma filter, you're going to treat a lot more volume. I mean, you're going to expose your cartridge to a lot more bilirubin because you're going to treat the whole blood flow, plasma flow of your patient going through the machine. When you're putting it on the effluent line of plasma, you're only going to treat how many plasma volume you extracted. So it might be 0.5, 1.5, but you get less exposure to the carbon because in order to extract that 1 to 1.5 plasma volume, especially on a membrane-based machine, you're probably processing 4-5 times as much volume on the blood side. So potentially, I feel like putting it in line might provide more bilirubin removal than doing plasma perfusion. That said, I mean, if we go back to the discussion we had about red blood cell fragility in these patients, I would be more worried about hemolysis through the carbon cartridge if I put it in line like that. Whereas if you put it on the plasma side, then you don't have any problem with hemocompatibility. You're not going to lyse your red blood cells. You're not going to remove platelets. So I think it's just a matter of what balance you're looking for. Are you going for more extraction, or are you worried because your patient is already thrombocytopenic, because that's an Evans syndrome, for example? Are you worried about red blood cell fragility? Then I would probably prefer to do plasma perfusion. So, I mean, again, it's just tailor the prescription to the patient, I guess.
One of the
It'll be
things
interesting
that comes
to
up.
see. Oh, sorry. Go ahead, Jethro.
No, actually, Chap, what you and Dan are doing, and Cedric may be able to chime in on this. One of the things that comes up when I think about the plasma absorption, plasma perfusion, is how we're taking out all those, the antibodies, the original target of the plasma exchange. Are you guys confident that those are all getting absorbed in that device as the plasma runs through it before you use that as replacement again?
A good question. So I think that it's sort of the order of operation that we've talked about it in the past and done it in the past is in these ones where we are really worried about the fragility. And, we've sort of treated on one platform and said, hey, is it the platform? Tried a different platforms for the second treatment. And with that fragility sort of component in mind, we ended up doing sort of the TPE portion first with an effort and hitting our antibody target, sort of almost separating it into two stages, right? Saying, hey, that's our primary goal is to remove antibodies first, doing TPE first, and then integrating in the carbon or whatever hemoperfusion device you're choosing to use, integrating it in for the second stage of the treatment, sort of more targeting sort of bilirubin clearance and other sort of pro-inflammatory clearances. So almost prolonging your treatment, but being more targeted with your therapy. So I don't think in that second stage we're removing enough from the antibody sort of component on the hemoperfusion device, and certainly not when we're doing plasma therapy. But we're trying to sort of reduce risk of fragility of those red cells and targeting primarily like bilirubin clearance.
Yeah, that's been my approach as well. On the patient I just showed, we did the 1.5 plasma volume exchange without the plasma perfusion, like regular exchange, again to target the antibodies or over plasma component that we want to remove with IMHA, and then we extended the treatment with the plasma perfusion because again, like if you're actually using the plasma perfusion and you're reinjecting the plasma to the patient, you might remove a lot of bilirubin, but you may not remove what you actually target for the treatment of IMHA. So the sequential treatment just makes sense to me until we have proof that maybe some hemoperfusion device might remove more, maybe antibodies or whatever, but we're far from being there, I think. But that could be interesting.
Yeah, that's perfect. I'm glad you guys both described that in a little more detail, because I think somebody that wasn't familiar with it would, oh, we just took the plasma and then ran it through and then gave it back. So perfect clarification.
Yeah,
really,
we
really
didn't
an
use the
important point there.
replacement fluid.
Yeah.
Good.
I think that there's some stuff I've just been reading a bit more on the Seraph filters, and I think that they did actually look at that in looking at antibody reduction and did not show any antibody clearance. So it would be interesting to replicate that in some of our other hemoperfusion devices, just so we can say for sure, unless it's already done and I missed that, which is very possible. But just looking at that antibody clearance being a minimal component of it with our other devices we're using.
I think things are getting done. So it's not just out yet, but I mean, some people are definitely working on it. And then the big question too, is just like, is antibody removal going to be the only factor to look at? Because I find it really interesting. For example, if you look at the myasthenia gravis dogs, you're decreasing the antibodies, but a lot of patients that have been treated in dailies, the antibody titers actually went back up to initial levels and the dog was not symptomatic. So antibodies might be a marker of a disease, but not always the cause of the disease. And maybe there's some plasma component that we're removing, whether they're cytokines or whatever, that are contributing to a disease at least as much as antibodies. And maybe antibody removal is not going to provide exactly the same results as TPE. So that's really exciting things to look at in the future, I think.
Cedric, I see Erica having some PTSD after a email I sent her in regards to efforts to make sort of some of our canine xenotransfusion blood products last a little bit longer in our felines by using some of our other hemoperfusion patients prior to transfusion.
Anyway. Well, I don't know if anybody has anything to. I've got a last little thing that is very anecdotal, but I had an alarm on my Optia on Tuesday. We were like we're planning to do a cell collection, and I was loading my ideal set on the Optia, and I got that screen where the cassette tray could not go down properly. The thing was not loading. And I was just staring at the machine, and the set was going down. The pump segments were engaging in the pumps correctly, but I kept getting that error. And I was about actually to blame the defective set and say, well, just let's pull out another one. And then I was like, you know what? I'm gonna call Terumo support because sometimes they have like good ideas on that. And as soon as I got on the call, she said, well, you probably have something that is stuck between the machine and the tray. So it cannot go all the way down, which is like, okay, well, I looked between the tray and the cassette, but I didn't look beyond the tray. And actually looking more closely, we had one of these little clamps, line clamps that had fallen behind the tray. So on top, that's a tray where you load your cassette, and it's going all the way down to load the pump segments. And so that was just stuck there. So just like that little thing was causing all the trouble and almost made me open up a $400 new set for nothing. And that's actually the ones that you have on the sets, like on the collection lines. So what I suspect is that the last cell collection we did, when we cut the lines with the little line sealer, one of those fell just in the right spot to get stuck beyond the tray. So yeah, if any of you get that kind of screen, just like make sure you look behind the tray for any foreign body that shouldn't be there.
The little things.
That's pretty unlucky, right? That it had to fall right in that spot. And also my machine, I moved my machine back and forth between my office and the treatment room. So, I mean, to stay there, it really had to be in a bad spot. And Brooke is saying that she had the same thing happen with the Amicus. So thank you. I feel less stupid now. Actually, that's a perfect segue because I mean we're at the end of the hour, and I think that was a very interesting discussion today. And I think that actually Brooke Davis signed up on the Sign Up Genius for next rounds to present a case of acetaminophen toxicity in a cat. Do you confirm that, Brooke?
Yes, I did.
Okay, so that's going to be very interesting. And so for those who same thing, if you go to the extent of like preparing a case for presentation and maybe make some slides and everything, you actually are welcome to go on the International Renal Replacement Rounds page on the ACVNU website. You can scan that QR code to the Sign Up Genius. Again, as Jeffro mentioned in the past, you don't need to sign up to attend the rounds. You can just like click on the link on the day of. You can sign up if you want to present a case. So we are sure that we're reserving you some time. And also that way we can study a little bit so you don't look too much smarter than we are. So maybe I'll try to find something interesting to say about acetaminophen toxicity by the next rounds.
Yeah, Brooke, we're excited to have you presenting next time. And again, like Cedric said, put as much or as whatever feels right into it. It doesn't have to be fully polished, but we'll take everything. Rafa's case today, amazing, great discussion to kick us off. So that's perfect. It can be as much or as little in terms of the presentation. All comers are welcome, and this was a great discussion. Thanks for everybody's input.
And thank you for everybody for participating. It's always like nice to have like different point of views and ideas and experiences. So. All right. Stop share the screen. Thank you so much, everybody, and we'll see you in 2 weeks.
Thank you, guys.
Take care. Goodbye, everybody.